In this video, we're going to go over how to properly fill out a body chart. Now, body charts should be filled out by the provider, not the patient. A lot of times places will have, a body chart for the patient to fill out, and that's all well and good, but we want a detailed one. There's a number of ways that we can do this, and some people may advocate for a more detailed way, but at baseline, we need to know where symptoms are and where they're not. So this one, we could see that symptoms are on the lower right back. They also have them here traveling down the side of their right leg, but that's it. Now, if that's all you draw is those areas, there's a lot I don't know. So this is so you can present it to me, or to anybody really, and that way when you look back, you know that you cleared it or if you didn't. And also when you're looking at it through the session, it makes you ask the questions that you need to. So this check here on the lower leg means you asked about the front of the leg. And this one means you asked about the back of the leg. Both very important. I wish we could go on the side as well. We could get a number of different views of this, but hopefully by checking both of those, that you touch the areas and it would elicit a response whether it kept going down, in this case like the L5 dermatome or L4 dermatome down here, and they would be able to say if there's any symptoms. We don't ask pain. We don't say is there pain here. We say any symptoms here. And we don't say is it traveling or is it shooting. Any symptoms here is the wording that is best. But something like this down the leg, that could also be hip OA. More likely it would be up front here in the groin, so I'm also asking there anything up front here. Or maybe it's a concomitant, so this way I know that you've cleared by asking in this specific area. Then we have checks on the left to make sure we're not getting bilateral symptoms. You can imagine if this is all you highlighted, but there was also bilateral numbness and tingling, that could be myelopathy, or that could be idiopathic peripheral neuropathy, or some diabetic peripheral neuropathy, some type of polyneuropathy, right? This also means is this, and then we also ask about behind the legs. This way I get a clear symptom. The symptoms are only where you marked, and that they're not having other symptoms that they didn't think were related, or that you just forgot to ask about. So then we go to the back. See how clearly I mark it's on the right there, not on the left. Now maybe they have pain across. Then we need to mark it on both spots. And then I go up near here, the TL junction. Any pain up through here, then I know that we asked about up higher in the back, and that where the pain is it's exactly right there. And by getting this detailed of a body chart, that means you had to question the patient that closely. Now we also go neck. Now there's a check mark here. Now this person could have had neck pain. It still may not be relevant, but it may be. And you want to never forget about asking about the neck. What if they say, oh yeah, I did have a fusion here. Or, yeah, I'm always painful here. Somebody with neck pain and concomitant back pain has a worse prognosis than somebody with just back pain. So that helps with prognosis and not just diagnosis. Or maybe it signifies that there may be a myelopathy here, because then the cervical spine is much more likely for myelopathy than in the thoracic spine. You could ask thoracic as well, and that wouldn't be a bad thing, especially if we're getting any TL junction. But I'm not as... the thoracic spine doesn't mean nearly as much for diagnosis or prognosis. If they're getting anything funky, or if there's bilateral symptoms, we would want to go into the thoracic spine as well. But the lack of bilateral symptoms here, and the lack of any symptoms in the neck, makes it a very low likelihood that any significant pathology that would change this plan of care would be in the thoracic spine. So again, we don't need to ask about the entire body. Notice I don't have anything in the upper extremities. I'm looking, if the neck was positive and there was anything bilateral here, then we have to start looking more. You can imagine that if the person just coming in here with low back and lower right leg pain, that if they also had bilateral foot tingling, bilateral hand tingling, numbness, and pain in the neck, that's a whole different presentation. Even if they say, oh, I'm just here for this. Well, we need to see the person and know that we're not missing something major. And by going through these, you just have to touch the neck. Any symptoms here? it's not a very much longer process, and it can make it so you don't miss anything big, or lower that likelihood a lot more in your career.